Hello, overcomers, and welcome to this episode of Connect Over Coffee. I'm Rincy, the founder of Overcome, and today we are joined by a very great friend of Overcome, Dr. Pedro Ramirez. Dr. Ramirez is the chair of the Department of OB-GYN at the Houston Methodist Hospital at the Neal Cancer Center. One of our esteemed advisory board members, Dr. Ramirez is regarded as one of the top gynecologic surgeons in the country and the world, and is a frequently invited lecturer for national and international conferences and meetings, where he continues to foster international scientific collaborations. Dr. Ramirez says education and access to information is crucial so that our patients are able to make the most appropriate decisions regarding their care. And that is what he's here to do today, share the latest information in ovarian and gynecologic cancers with an emphasis on surgical advances so you may feel more empowered to make the best decisions. If you have any questions as we go along and as we watch, please put them in the comment sections below and we'll get it addressed post the discussion. This is more of a structured program, so we'll take your questions. We'll share it with Dr. Ramirez, and when we get his responses, we'll post it back in the comment section. So with that, a huge welcome back to you, Dr. Ramirez, to this episode of Connect Over Coffee. Always such an honor to have you with us.
Well, Runzi, thank you so much for the invitation. It is absolutely a pleasure to be back here. And congratulations to you and all the great work that Overcome has done over the years. And thank you to the patients and family members who are listening. Really a pleasure to be here.
Thank you. That was beautiful, by the way. So speaking of, beautiful, just continuing on that note, just reading up on you, it seems like you were a double major in literature and biology, and you wanted to be a literature professor, but became a globally renowned gynecologic oncology surgeon instead. So tell us your inspiration and why you chose to be a surgeon in particular.
Yeah, wow. Not the typical question that I usually have in these medical settings and webinars, but yes, of course, I love to talk about my interest in literature. You're absolutely right. When I was at university, I was double majoring in both Latin American literature and then also in biology at that time. I loved it. I mean, I thought it was really a wonderful opportunity to learn about all of these masters in the area of literature, and particularly Latin American literature, and from other regions as well. So till this day, I really enjoy reading, and I do have some really very great favorite authors that I can recommend. But again, I mean, obviously the interest in medicine was really more of a personal and family related. My mother was diagnosed with breast cancer, and she was treated for breast cancer, and she was an inspiration to me. And ultimately, again, I think that even from the very beginning of my interest in medicine, oncology was in my path. So to that end, of course, obviously, I went to medical school, and then in residency, when I was in OB-GYN residency in New York at Columbia University, then I really felt that gynecologic oncology was the field that I would pursue. And yes, of course, yeah, the rest is history.
That's wonderful. And this is why I asked you the question first, because it sets the tone for the rest of the conversation, that you bring a personal connection to what you do. And that is so important. So thank you for sharing the personal story behind why you decided to become a surgeon. So before we get into the specifics, can you tell us about the different types of surgeries that are related to ovarian cancers, and what should our overcomers know about the options that are available to them?
Yeah, so that's a really great question to start this discussion. So, of course, as you know, ovarian cancer can be diagnosed at early stage versus advanced stage disease. Um, the majority of patients are diagnosed with advanced stage disease, typically stage 3 or stage 4, as many patients may not present with very distinctive symptoms or specific symptoms. Many patients usually will present with increasing abdominal bloating, fatigue, and just a overall slow process of just not feeling well. And many times these symptoms are attributed to other things, and particularly again in a perimenopausal or postmenopausal population, there's often the discussion as to whether these symptoms are attributed to gastrointestinal issues, urologic issues, and ultimately a diagnosis is made in advanced ovarian cancer. Then there's the patients who are diagnosed with earlier stage disease. Those are the patients that typically are diagnosed with a coincidental mass in the ovary or a cyst in the ovary, looks concerning, an ultrasound is obtained, and then ultimately a visit with a gynecologic oncologist leads to the diagnosis. Now, for early stage disease, typically because the disease is confined to one ovary, generally the approach is a minimally invasive surgery, which means a laparoscopy or robotic surgery. For our patient population in the audience, when you hear minimally invasive surgery, again, it encompasses both of those modalities. So in discussions with your physician, if the terminology of minimally invasive surgery comes up, I think certainly it's worth discussing as to which specifically and the level of expertise that surgeon particularly has with that approach. But again, it's been shown that in an early stage disease, typically minimally invasive surgery is the appropriate approach. And I say typically because obviously that also depends on the size of the mass. And generally, one would not consider minimally invasive surgery if there is a mass that exceeds about 12 centimeters or so, because ideally, if it is concerning, then ideally one would want to remove that mass intact. So then therefore that's important to have that discussion with your physician as to whether they consider that we can remove this mass or this cyst safely through a minimally invasive approach. And then, of course, then for advanced stage disease, traditionally the approach has been an open surgery. And oftentimes the patients will ask, well, are you going to go through my C-section scar or are you going to go up and down? And generally the appropriate incision, although cosmetically may not be as aesthetic, the appropriate incision is an up and down incision, a midline vertical incision. And the reason for that is because not only do we need to target the disease that is in the pelvis, but also we need to evaluate the upper abdomen. Often we need to do surgery in the upper abdomen, removing the omentum, which is this fatty tissue that covers the bowel. Oftentimes there may be a need for resection of tumor from the diaphragm, or even in some cases performing a splenectomy.
Surgery in ovarian and gynecologic cancers, as I understand, have gone through and continue to go through iterations. So tell us what is latest in terms of surgical approaches in ovarian cancer in particular, and what should we know about new surgical advances in 2026?
Yes, so I think the overall theme, and not just actually in ovarian cancer, but across gynecologic oncology, is the word de-escalation, meaning we're doing less aggressive surgeries, less extensive surgeries. And particularly in ovarian cancer, it's important to highlight that for many, many years, the thought was you always have to do surgery and then follow that with chemotherapy. And then there was a thought with regards to perhaps we can give chemotherapy first, reduce the size of the tumor, actually make it a less aggressive surgery later, and actually have a much more effective surgery after chemotherapy. So, of course, there were many debates because those who felt very strongly about surgery stood their ground and said, no, of course, we have to do surgery first. And frankly, for many patients, even till today, when you talk to them about giving chemotherapy first, you kind of see sort of like this look of disappointment of like, oh, but why not surgery? And there have been a series of studies, now numbering a total of 5 studies, that have looked exactly at this question. Is it better to do surgery followed by chemotherapy? Or is it better to do chemotherapy followed by surgery? And we had 4 studies, and until recently, there were only those 4, yes. And now we have a 5th major study, and we can perhaps talk about that a little bit later. But all 5 studies showed that there was no difference on whether you did surgery first, followed by chemotherapy, or chemotherapy first, followed by surgery, in terms of oncologic outcomes, in terms of overall survival. So a lot of times when patients ask, well, which one will make me live longer? There is no difference between either one. However, there is a difference that you have higher complications if you do surgery first than if you do what is called interval surgery. So then, therefore, the field has moved from, as an example, when I started in gynecologic oncology, it was very rare that patients would undergo chemotherapy first. It was maybe 10, 15% of patients undergoing chemotherapy first, and everybody else got surgery. Now it's completely the opposite. Now it's about 80 to 85% of patients getting chemotherapy first, then followed by surgery, then additional chemotherapy. Now, in terms of the surgical advances, one thing is that, as an example, because if you do interval surgery, in other words, surgery after chemotherapy, your disease volume is going to be a lot less. So now there is a proposal for doing minimally invasive surgery rather than open surgery in patients with advanced ovarian cancer, but doing minimally invasive surgery as part of the interval surgery. Now, in addition, you might say, well, what about like really innovation rather than just which approach you take? There's been some studies recently looking at infrared technology, so fluorescence, where you basically inject this fluorescent agent into the intravenous line of the patient while they're undergoing surgery. And the thought is that when you look with your eye and you see no other evidence of residual disease, then you inject this agent, and then it'll show you when your eyes couldn't see it with this special camera where there's still disease left, and then one can potentially remove those segments of tissue that are still consistent with residual disease. Very experimental, not part of the standard, being evaluated. We don't know if it'll be part of standard practice in the future.
So one question, as you were talking about, that 80 to 85% patients now go to the neoadjuvant route. So for the 15% that do not, that get surgery first, how do you make that determination?
Yeah, very good question. That's right. So generally, the idea of doing surgery is that you're going to remove all of the disease that you see. If you're not going to remove all of the disease, then surgery should not be performed. So in the past, again, distant past, many surgeons would say, well, let me just take out as much as I can. And that's got to be better than leaving everything and giving chemotherapy. And in fact, it was shown that that concept absolutely has no scientific basis. So that if you're going to effectively impact the survival of that patient, you have to remove all of the disease that's there. So now, with such great imaging studies, with all of the modalities that we use to evaluate patients, now we can have a really good sense of, will I get to remove all of the disease in this patient or will I not? And when you feel that you're going to be able to remove all of the disease, as an example, in a patient that has a mass in the ovary and disease in the omentum and nothing else, everything else looks fine. The liver looks fine, the spleen, the stomach, the bowel looks fine. Then you might say, well, yeah, I mean, I should do surgery on this patient because I have a very high chance that I'm going to remove all of the visual disease that is there. But now with such good imaging, it can tell you frequently, well, you have enlarged lymph nodes, you have disease in the surface of the bowel, disease in the surface of the colon, you have disease in the mesentery, which is this fatty tissue that covers the lining of the abdomen. So then you would choose generally to just do a biopsy, confirm the diagnosis, and go to chemotherapy.
Okay, thank you. So we also understand that the timing of surgery in ovarian cancer is critical, as you have been talking about. I was reading about the TRUST trial and its findings and implications. So what would you like to share with our overcomers about this particular trial?
Yeah, for those who are not familiar, certainly the question has been there for many years. The question of whether you should do surgery first or chemotherapy first. As I mentioned, there were four studies,
Yes.
four studies that had looked at this evaluation. And yes, those four studies, if you look at them individually, there were some criticisms of one or the other. And one of the criticisms that were made by the surgeons who felt strongly about surgery first was they didn't have the appropriate surgery. The surgeons in those studies might not have been from high volume centers. The surgeons in those studies might not have had the skills necessary to do what is called optimal surgery. So then they said, forget about the results of those four studies. We, group of master surgeons, are going to actually do that study with really good surgery. And we'll show you that surgery is better than chemotherapy up front. So, yes, it was very well-known surgeons from around the world, primarily from Europe and some in the United States. And there was actually a very strict criteria to enter onto the study. The surgeons had to be evaluated and determined to be expert surgeons, high volume surgeons. And then there were site visits that were done. So all of the components to really show that these were like outstanding surgeons doing the surgery. So they actually called the study the trust trial. In other words, we don't trust the other four studies. You got to trust this one. So after many years, and it was a prospective randomized study where patients were either surgery followed by chemotherapy or chemotherapy followed by surgery. What it showed was exactly the same thing as the other four studies. There was no difference in overall survival. And of course, obviously, when surgeons oftentimes will do a study and they don't like the results of the study, then they will start looking at like, well, was there anything positive that agrees with our bias? And that study was clearly a negative study. A negative study means that it didn't show any difference in overall survival. But it's important for the patients and their families to have an understanding, because for surgeons who are biased towards doing surgery first, they will point out and say, well, look, in that study, the disease-free survival was better if you did surgery first as opposed to doing neoadjuvant chemotherapy first. That's a secondary analysis. And of course, obviously, this is kind of where it gets a little bit into the statistics. But a secondary analysis cannot be a conclusion of a study. It is just a hypothesis generating, meaning we saw this signal. It may be true. It may not be true. You always go by the primary objective. The primary objective of the study was overall survival.
Right.
There was no difference in overall survival. So many surgeons will say, yeah, forget about the primary objective. But look, in the secondary objective, they showed that surgery was better in the disease-free survival, which basically means the time to recurrence. And they will draw that as sort of like their excuse to propose surgery first. But in conclusion, in summary, 5 trials that show that there is no difference.
And so you bring up a really good point. What you said is that for the surgeons who advocate towards the surgery first would often tell you about the progression-free survival, right? And that is what you should focus on. That is also an important criteria, but it also is what it's telling me that the patients need to be more educated and informed about the choices that they're making, and it should be a collaborative decision with the surgeon, knowing all these facts, that the overall survival really isn't changed, even if you do the debulking first versus you go to the neoadjuvant route. So that's very important.
Yeah, definitely very, very important. And particularly, again, when having that discussion with the surgeon or the gynecologic oncologist, obviously, the question should be, well, you're proposing surgery first. What's the likelihood that you're going to get all of the disease out? Not just most of it out, all of the disease. And what are you basing that on? And again, if you see somebody that a patient presents with advanced ovarian cancer and they have disseminated disease in the abdomen, your family member has disseminated disease in the abdomen, ascites and fluid, and they go, oh yeah, let's go to surgery. I would say perhaps look at a second opinion. And a lot of times, the patients will say, why would I want a second opinion? I want surgery. you may have surgery. It's not going to be the right surgery. I mean, you could have surgery anytime, but is it the indicated surgery? No. And are you going to be prone to more complications? Yes. And this you may have a surgeon who says, those people that don't like to do surgery first, they're just not, I mean, they're weak surgeons. Somebody like me, watch, be careful, stay away from somebody like that. In my hands, I can do optimal surgery on everybody. Stay away from somebody like that.
Okay, thank you. So, and I was one of the physicians that I interviewed in one of the other episodes, and you alluded to that too, said that a good surgeon knows how to operate, and a brilliant surgeon knows when not to operate. And you talked about it a little earlier. And so when, how do you select patients and candidates on surgery versus not? And then how do you how do you design their treatment protocol, and what should the overcomers know and ask
Yeah.
their surgeons when these decisions are being made?
Yes, I completely agree with that statement. And I think that the wiser you get, the less surgery you offer patients.
Yeah.
And why do I say that? Because obviously we want our patients to do best, and we want our patients to not suffer from complications. We want our patients to have good quality of life, and we want our patients to live, right?
Mhm.
So the decision making. Fortunately, today we have much better tools. So obviously we have much better imaging studies, much better machines. The images cuts are much narrower, so obviously we can see better. And therefore also the radiologists are also much more in tune to knowing what we need to know. In the past, you would get a radiology report in a patient with advanced ovarian cancer that was said mass in the ovary and carcinomatosis. And you say like, oh, okay. And then this is where, you go in and it was like those patients say, oh, they opened her and closed her right away
Yeah.
because there was
Mhm.
just very poor technology to determine the extent of disease. So today we have much better technology that we're able to determine what patients we have the highest chance of removing everything that's there. So typically, if a patient has disease outside of the abdomen, meaning the lungs or anywhere else, not a candidate for surgery. If a patient has liver metastases, disease in the liver, in the body of the liver, not a candidate for surgery. If the patient has metastases throughout their lymph nodes, not an ideal candidate for surgery. If a patient has involvement of the stomach, multiple parts of the large and small bowel, not a candidate for surgery. And if the patient has what is called serosal disease, so meaning all on the surface of the bowel, not a candidate for surgery. So then, therefore, as you see, that list is getting longer and longer and longer. So then any one of those then already excludes you. And then you go to neoadjuvant chemotherapy. And you might say, well, take all of that out. Um, I mean, you can't. You cannot take out the entire bowel. Technically, of course. Yeah. I mean, a surgeon can remove anything in the body. Will the patient live after the
Right.
surgery? Then that's obviously the important component. So the idea is to remove what we consider is safe and optimal, that we will be able to remove all of the disease that is there.
So one question on this, and just to follow up, we talked about the neoadjuvant and the upfront debulking, but in certain patients, is surgery not performed at all, given that, like, not even like neoadjuvant, not just no surgery based on their disease state? Is that something that you would recommend, or?
Yeah, so I think that question is two parts. So the patient that is not a candidate at all for surgery is typically, again, the patient that I described in terms of those imaging studies, but also say, for example, if a patient is so debilitated, elderly patient, 87-year-old that comes in really debilitated, not eating, in a wheelchair with all, and oftentimes it's difficult because the family, often the children are like, operate on mom, of course. And they don't see that operating on mom may be that mom may never actually get out of the hospital alive at that age in that condition because of the type of surgery that would require to address that disease. So then, therefore, we not only look at the imaging studies, but we also look at the condition of that patient. So in that patient, definitely biopsy, neoadjuvant chemotherapy. Now, the other question, and that's a question that is coming up more and more recently, is that patients with neoadjuvant chemotherapy usually respond very well. So a patient comes in with lots of tumor, and the surgeon says, you're not a candidate for surgery. We're not going to be able to get all of this out. Let's start with chemotherapy. And after 3 cycles, they have a really good response. And you say, well, now we can go to surgery, or we can potentially do 3 more and then go to surgery. And many patients are like, my quality of life now is actually much better. I'm back to my normal daily activities. I get my chemotherapy every 3 weeks. Let's do 3 more. They come back after 3 more. You do imaging. The disease is gone, completely gone. Then the patient's like, hey, do I really need surgery? I mean, like right now, I'm, having a great quality of life. I'm seeing my patients, taking care of my children, my grandchildren, and and you're telling me the scans are negative. Why do I need surgery? So generally, still the recommendation is to remove the ovaries and the uterus, of course, a hysterectomy, and if there's any other evidence of disease. But if the imaging shows no evidence of disease, you typically have just basically a normal uterus and normal ovaries. So then that's a question that I think now is being further explored. And as we're getting treatments that are much more novel and much more targeted, added to the neoadjuvant chemotherapy, now we're starting those conversations. Hey, what about if patients with ovarian cancer, advanced ovarian cancer, never need surgery because our treatments are so good in the therapeutics, in the chemotherapy and novel therapeutics. So it's a question that is being explored, and I wouldn't be surprised if 2 to 3 years from now we're talking again, and we're talking about, like, remember when we used to do surgery on patients with advanced ovarian cancer? So
Wonderful. So I would love to see more about this in 2026, especially for some patients where surgery doesn't make sense and chemotherapy is doing its work, then logically speaking, there is no need for that intervention. So it's great that you all are thinking in that path. So thank you. In terms of, when you do, and you talked about the complications that arise from surgical interventions, right? So typically after surgery, what are the absolute red flags for our patients that require immediate care? And because we hear from our overcomers oftentimes that it feels like we call the doctor's office very frequently, very often, and we don't even know whether that's necessary. But just to empower our patient community after a surgery, what are the absolute red flags they need to report immediately and be mindful of?
yes. Well, I think it's also very important to have a conversation with your surgeon prior to the surgery as to what to anticipate in the perioperative period, meaning, what do I anticipate the day I'm getting surgery? What do I anticipate in the recovery room? What do I anticipate in the time that I'm recovering in the hospital? And then within the first week, within the first month, what are some of the things that I will be anticipating? I think, of course, obviously every patient is given instructions on discharge, and family members are given instructions on discharge as to any fever. Of course, that's a red flag. Any increasing redness or swelling of the incision, any bleeding, any vaginal bleeding, any bleeding from the incision, any nausea, vomiting. And one of the things that I always tell patients is that once you leave the hospital, every day should be better. So, when you leave the hospital, it shouldn't be like, oh, I was feeling great for 3 days and my God, I feel horrible now and then horrible again. That's not normal. Every day should be like, wow, today is much better than yesterday. And if that's not the case, that's a reason to at least obviously contact your physician, or their office, and let them know these are the things that I'm going through. Now, the other things also, here at Houston Methodist, one of the things that we implement, and we can talk about the perioperative recovery, but in terms of just the assessment and evaluation of patients, one of the things that has been shown to decrease readmission rates is to see your patients, see them, not just call them, but actually see them within 7 to 10 days of surgery. So now every patient that we discharge, we give them an appointment to come back to clinic within 7 days, even if they're doing great. We just want to make sure that as we look at the incision, want to make sure that their eating is okay, their bowel habits are okay, they're urinating okay, because it's been shown that if you do that, you decrease the readmission rates. Because a lot of times it's either addressing some of those comments, as you mentioned, that may really not be of any seriousness, but also seeing a patient that may not have perceived that their symptoms are actually really serious and that they really need to come into the hospital. So that's one of the things that we are now routinely doing here as well.
Wonderful. And any recommendations from you in ways to recover faster from surgery that you would
Yes.
share, would like to share?
Yes. And frankly, that's one of the things that you should ask your surgeon, frankly, regardless of what surgery you're having. I about a year ago, I had a right knee meniscus surgery, and I was more actually interested in whether my surgeon implemented enhanced recovery after surgery protocols than what he was actually going to do to my knee. Because, I know that he knows what to do with my knee, but I was worried about my perioperative recovery. And that's really important. And that's called ERAS pathway, stands for Enhanced Recovery After Surgery. And basically, these are implemented steps of things that we can do in the preoperative period, intraoperative period, and postoperative period to have the patient recover sooner. And it doesn't mean to have the patient leave the hospital sooner. Leaving the hospital sooner is one of the benefits of enhanced recovery. But a lot of times when you explain enhanced recovery to patients or doctors, they may say, oh, you just want me out of the hospital sooner, right? No, actually, we want you back to your functional daily activities sooner. So as an example, we actually did a study and published, when you implement enhanced recovery pathways in a patient with advanced ovarian cancer, so typically the time when that patient feels like, okay, I'm really back to feeling normal again, feeling back to my day, without enhanced recovery was about a month after the surgery. With enhanced recovery, it was about 7 to 8 days after the surgery. So what do we do with enhanced recovery? Among those measures, there's medications that we use to reduce nausea, vomiting. We focus on normothermia, meaning maintaining adequate temperatures during the surgery. We focus on giving the appropriate antibiotics around the time of surgery. We focus on giving medications to prevent blood clots. We focus on decreasing the amount of intravenous fluids that patients get. It's been shown that if not on an enhanced recovery program, patients tend to get a lot of intravenous fluid in the surgery. And then that leads to inflammation, that leads to nausea, vomiting, delayed bowel function. So we limit the amount of intravenous fluids. Very, very importantly, we limit the amount of opioids that patients receive in the intra period, in the postoperative period. And then therefore, all of these elements provide an opportunity for the patient to recover much quicker. We feed the patients much sooner. We have the patients walking much sooner. So all of these elements, and patients, remember when patients used to get these opioid pump machines with a button and they would keep pressing the button? None of that is done anymore under an enhanced recovery program.
That's wonderful to know. It sounds very minimalistic, and it's logically telling me that it's easier for the body to recover. Even if I'm not medically inclined, just from logically understanding you, it's just like less intervention, quicker recovery. It's as simple as that. So
yeah. No question. And I mean, and it's the natural thing that the body requires. I remember prior to these implementations, and even when I was in residency, we were taught, it was like, you do surgery on a patient, it's like, oh, don't give them anything to drink or eat until they pass gas.
I remember that.
Oh my God. And the poor patients were like 5 days after the surgery, and like, I'm dying. I'm like, I'm dying of thirst. I'm dying of to have something to eat. And then the doctors would be like, no, you must pass gas before. And I was like, oh my God, what torture. And now it's completely the opposite. The day of your surgery, you're drinking. The day of your surgery, if you haven't had a bowel resection, the day of your surgery, you are getting a regular diet that evening. Just eat normal. and walk. And so it's all about getting out of bed, eating, walking, and having no opioids. Because again, I mean, the opposite is overloading with fluids, that opioid machine that is making you very nauseous, very constipated. It's a completely new way.
Wonderful. Thank you for sharing, Dr. Ramirez. So, HIPEC, is it still in practice? And tell us more about it. And because I feel like it's kind of losing its place in the field a little bit. So, where are we with
Yeah,
HIPEC?
HIPEC, for those who are not familiar, is heated intraperitoneal chemotherapy. So basically, you do this major surgery, and then after that, you pump heated chemotherapy into the abdomen, and then subsequently additional chemotherapy after. It never really caught on in the United States. And why? Because there was really never any good evidence to support that it was better than what you did as standard surgery. HIPEC kind of came associated with these like major radical surgeries that we used to do. Now, as I mentioned before, we don't do those major radical surgeries. Most patients get chemotherapy first,
Yeah.
and very simple, low complex surgery, or, as I mentioned, maybe in the future, even no surgery at all. So as you're moving towards a de-escalation, as you're moving towards less aggressive surgeries, then HIPEC hasn't really been part of the standard. Now, is there any benefit at all in the setting of ovarian cancer? Yes. There was a study in patients undergoing interval reduction surgery, interval cell reduction surgery. So chemotherapy,
Yeah.
then HIPEC with surgery, and then chemotherapy. The criticism for that approach is that there is a much higher rate of complications associated with HIPEC than without HIPEC. The other thing is you have to have a center that does this routinely, constantly. You have to have experts in the field to be able to do the appropriate surgery and HIPEC. So if you go to a center that they start talking about HIPEC, is, well, what's your experience with HIPEC? Who does the HIPEC? And particularly also because HIPEC is often done by someone other than your surgeon, then your surgeon can tell you, oh, look, we can operate on you in 2 weeks. And you're like, my God, I want surgery tomorrow because I have advanced ovarian cancer. However, if you add all of the HIPEC and all of the coordination, it's in about 5 to 6 weeks. And then you're like, great, I have advanced ovarian cancer. I have to wait 6 weeks to get HIPEC. And then, granted, there'll be somebody that listens to this and says, oh, I do HIPEC in my hospital, is no problem. It's exceedingly rare that you have a very well-established program in HIPEC. So for the patients where that word comes up, A, it should only be coming up in the setting of interval surgery. And then B is, am I your like 10th HIPEC patient, or am I your like 150th HIPEC patient? And also, let's talk complications, and let's pause and really focus on complications. Tell me what they are. And if somebody says, oh, we got no complications, oh, everybody tolerates it fine, run.
I love this, Dr. Ramirez. This is so empowering for the patients. Thank you for the candid conversation. So I hope the overcomers have taken notes on HIPEC. So you are recognized as one of the leading surgeons in the U.S. and in the field of fertility preservation in young women with gynecologic cancers. So for our younger overcomers listening, can you tell us very briefly, the recommended guidelines for women that wish to plan for childbearing after ovarian cancer? What would be your guidance to them?
Yeah. Yes. So let's talk first about advanced ovarian cancer. In the setting of advanced ovarian cancer, generally patients will have a hysterectomy because typically you generally don't have advanced disease and a completely normal, untouched uterus. Usually the ovaries sit next to the uterus, obviously, and then it's usually a conglomerate of tumor. So generally you don't maintain the uterus in advanced ovarian cancer. The other is, well, can you stimulate the ovaries and harvest eggs? And no, because obviously you need treatment like right away. Um, Early ovarian cancer. Most patients, fortunately, present with just disease in one ovary. So
Mhm.
oftentimes the uterus is left in place and the other ovary are left in place. Now, remember also, one of the things to consider is that in advanced ovarian cancer, most tumors are called epithelial tumors. So serous, high-grade serous carcinoma. So those are in younger women, fortunately, that's not the predominant tumor. So the predominant tumors are called germ cell tumors or sex core stromal tumors. You might
Mhm.
have heard some of them granulosa cell tumors, there's germinomas. Um, for those tumors, usually you just remove one ovary, the affected ovary. Also, fortunately, for those patients and those tumors, the majority don't recur. So early stage, just remove the ovary, rarely likely to recur. So then, therefore, those patients can certainly look at future fertility. One of the things that we often discuss with them is that, if you were diagnosed with these types of tumors and you might not have undergone chemotherapy, or you might have undergone chemotherapy, we wouldn't say like, okay, try to get pregnant like, a month after, 2 months after you finish your treatment or you had your surgery, because ideally you want to wait. Most patients want to wait because even though they have good prognosis, there can still be recurrence. So we usually tell patients, wait a year, maybe 2 years, see if everything's going well. Because ideally, obviously, you don't want to get pregnant and then have a recurrence of disease. And if that disease doesn't respond, then it's
Mhm.
going to be a child without a mother.
Mhm.
So then I think it's important to at least give it 1 to 2 years after the diagnosis to make sure that you're going to be okay.
Just one question on this. What about the low-grade serous LGSOC
Yeah, the
overcomers?
low-grade serous carcinomas, number one, they're rare. Number two, certainly again, if you have advanced disease, fertility not a possibility.
Mhm.
If you have early stage disease, then I think it's the same principle.
Right.
Most of those patients don't even need chemotherapy. Many times they're placed on hormonal therapy
Right.
afterward. And again, I mean, I think it would be the same advice. Wait a year or two and then see if everything's okay, proceed and get pregnant.
Okay, thank you. So, for overcomers that are recently diagnosed or experiencing their second, third, or multiple recurrences in certain situations, what options do you see emerging in 2026? Because there's so much happening in the field of gynecology cancers. So, how do you see 2026 evolving
Yeah,
forward?
incredibly optimistic,
Yeah.
incredibly optimistic. The days of, well, you just failed this chemotherapy, now you go on to this other chemotherapy, then another chemotherapy, those are pretty much gone. Now, when patients have recurrences, we have novel therapies, antibody drug conjugates, targeted therapy that we're looking at molecular profiling. And the patient should always ask in the recurrent setting, always, if your doctor doesn't say, let's do tumor testing or molecular profiling, that should be a red flag and say, why are we not doing this? Because that helps us guide treatment. And how does it help us? Then it's basically looking more at your specific tumor. And does your tumor have a particular type of receptor? Does the tumor have a particular type of mutation that we can actually specifically target with these really effective treatments? And you might say, well, what do you mean by really effective? In the past, you got a chemotherapy at the second recurrence or third recurrence, response rate's about 15% at best. And you went to the next chemotherapy, and if your response rate was 15% in that one, then this one is about 10%, and the next one is 5%. So basically, I mean, not really optimistic. With some of these newer options, you're getting either complete response, meaning tumor completely gone, or partial response in about 30 to 40% of patients, and a clinical benefit in about 80% of patients. And you say, well, like, what's clinical benefit? The clinical benefit means that you don't have to go on to a different treatment. How so?
Mhm.
Your tumor went away, your tumor got smaller, or your tumor didn't change, meaning we're holding it at bay.
Mhm. Mhm.
So many of these patients are now getting treatment for, sometimes years with these novel therapies, and the tumor's not growing. It's not going away, but it's not growing.
Mhm.
It's not impacting their quality of life because most of these drugs are fairly well tolerated. So then patients are able to pretty much continue on with their lives with a chronic disease.
Exactly, and that's what we keep talking about this in our episodes, that even if there is no immediate cure for ovarian cancer, we want to take it to the next level where it becomes a chronic disease like hypertension or diabetes, where it is controlled and you have the quality of life that you wish for. You travel, you see all the things that you want to see in terms of milestones and achievements. So
Mhm.
that's beautiful that we are moving towards that. So I know that you are part of a few major ongoing clinical trials, or you either a part or leading. Tell us about those and how our overcomers may find more information and enroll if they wish to.
Yeah. Yeah. So as I was mentioning, because now we're finding more and more targets. In other words, in the past, we didn't really know like what were the mechanisms of these cells becoming cancerous cells. So now there are targets that help us determine, well, if you block a particular target, then that cell cannot grow. Or if you block a particular gene, then that cell will auto kill itself. Um, so now fortunately, there are many strategies to target some of these, and many are being investigated through different types of mechanisms. And it's exciting, obviously, because if you test a patient and there is actually a receptor positivity and you have a drug that can actually target that, you're starting to see really, really great results. The only way we're going to know as we move forward how to broaden those options is through clinical trials. So
Mm-hmm.
how do you learn about those clinical trials? Certainly visit the website of the different centers,
Yeah.
visit with a physician there, and learn as to what are all the options that we have for our patients. As I said, when I started here at Houston Methodist, we had 3 clinical trials. Now we have a total of 25 clinical trials, 15 more trials opening in the first quarter of 2025. These are trials for cervical cancer, endometrial cancer, ovarian cancer.
You mean 2026, right?
Yes, 2026. Yeah, the first quarter.
Right. Okay.
Yeah.
Yeah.
Yes.
That's
So yeah,
wonderful. Yeah.
so we will have about 30 to 35 prospective studies for patients with gynecologic cancers.
That's wonderful. And so, if I would also mention that we do have a clinical trials website page where you can go and just search by ovarian cancer trials only. So look up Houston Methodist and see what the trials are available. As Dr. Ramirez mentioned, there are about 25 trials that are about to open in 2026, first quarter. So keep an eye and let us know if you need any help with those. And then in terms of you mentioned the PARPs and the ADCs and all that, the targeted therapies. From a surgeon's perspective, though, how do you perceive these targeted therapies in terms of the overall patient well-being? Just briefly.
Yeah, I mean, from a surgeon's perspective, I'm so glad to see that patients are doing well, because it would be kind of disappointing to see all of these options, but impacting the quality of life of those
Nothing.
patients. So to me, to see patients that are coming in and they're doing well, I have patients who are coming in, getting their treatment and getting on an airplane and going to Europe and visiting family or vacationing. I had a patient that she's on a drug called mirvetuximab, which is a folate receptor inhibitor and antibody drug conjugate. And she was treated here, got on an airplane, went to Madrid, and she has a beautiful apartment in Madrid. And she was like, I feel great. And actually, I'm going to stay here much longer than I had anticipated. Can you find me an oncologist that can continue this treatment in Madrid? And, like the disease is not really running her life.
Wonderful. That's fantastic. So, and we are almost at the top of the hour. Dr. Ramirez, I've asked you a lot of questions. I must have missed something that you would like to share. What have I missed asking you?
I mean, I think that, obviously we talked about very important and pertinent topics, surveillance and what happens after you are a survivor, right?
Mm.
And I think it's important to taking care of yourself mentally, physically, learning how you can get back to your functional daily activities, how you can get back to, obviously enjoying life, looking at resources that look at what are the opportunities for wellness moving forward. Again, be it mental, physical, sexual. There's so many options today to consider. Support groups. Just again, of course, obviously, there are patients who find the support in family, friends, but really focusing on recovery rather than lingering on this disease.
I love that message. Thank you, Dr. Ramirez. And so, in closing, and you know this question that I've asked you before, what message of overcoming would you like to share with all our overcomers and audience listening today?
Yeah, I think you actually touched upon some of these earlier. I think is learn, be well informed. Don't be afraid to ask questions. Any question that seems like a good question to you is a good question. Don't be afraid to ask. And again, be critical of those who are treating you. Be assertive in terms of your questioning. And again, you have to feel that you are in the right setting with the right physician that is taking care of you personally. Not a medical record number, not a disease site, not a case, somebody that's taking care of you personally. And then always, remember there's hope, always hope in this disease, and always look to your life long term. Don't stay in your mind frame in the disease. Get out of that and move towards a cure.
Thank you so much, Dr. Ramirez. This was beautiful, and you had some such empowering guidelines and guidance that you provided to our overcomers, and we appreciate your candidness and all that you shared with us today. Of course, you shared a lot of knowledge, which is given, but all this candidness and the real life guidance that you offer to our overcomers, we're very appreciative of that. And so, overcomers, hope you enjoyed this conversation. And as I mentioned, if you have any questions, please put them in the comment sections, and we will share it to Dr. Ramirez and come back to you with the answers. Post them in the comment section. So we will be back with the next episode of Connect Over Coffee very soon. Until then, you keep inspiring and keep overcoming. Thank you and bye.